Today, we will be discussing a very important topic, that of cataracts. It is the number one cause of blindness in the world. In developing countries, it's always number one. In developed countries, it's either number two or number three. But cataracts can be reversed through surgery, and if replaced by an intraocular lens, your patient should be able to recover their functionality and their sight. So let's discuss how to identify cataracts, what is cataracts, and later on how to treat cataracts. So we'll start with one of the more famous stories about cataracts, that of the national hero of the Philippines, Dr. Jose Rizal. And as far as I know, he's the only national hero who's an ophthalmologist. The story goes that his mother started to develop cataracts, but there were no ophthalmologists in Asia during that time. The only ophthalmologists were either in America or in Europe. So he studied in Europe to learn how to become an ophthalmologist, and when he returned, he is the only ophthalmologist in Asia, and he performed the cataract surgeries of his mother. Now, at that time, it was very, very tedious because they didn't have any sutures. They have to mix their own medications. So it was very, very crude, but his mother was able to regain sight. So let's talk about the lens. We call it the crystalline lens, or simply just lens. Now, we want you to understand the anatomy of the lens because it's very, very important for you to understand what happens when a person has cataracts. Now, a lens is transparent, it's biconvex, and it's crystalline. Now, I want you to remember it's transparent. Now, the lens is actually in between the iris and the vitreous. And in the vitreous, it's actually like a gel. It is located in a saucer-shaped depression called the patellar fossa. Now, it looks like this. The arrow is actually pointing to the lens. That white football shape or bean-shaped object is your crystalline lens or your lens. Now, notice that it is actually behind the iris. It's peeking through the pupil, and at the back of it, that large bluish gel is the vitreous. Now, that part where the lens is sitting is actually intact. If you remove the lens, you will be able to see that shape. But if you disturb the vitreous, if you rupture the vitreous face, then that patellar fossa will actually disappear. Now, the lens is placed particularly well because it will focus the light coming from the outside, going through the cornea, and through that small opening in the pupil will be the lens will be able to focus it into your retina, in particular to your macula. So it's very important that it becomes clear. It's very important that it functions well, and it's not just a simple lens. It's actually controlled by the muscles of your ciliary body. Now, the lens itself is about 9 to 10 millimeters in diameter. It's not really that big, but the older you get, it becomes thicker. We'll explain to you later on why it becomes thicker. So, at birth is about 3.5 millimeters, and usually by the time you're 80 years old, it's about 5 millimeters. It's not that much, just 1.5 millimeters, but that 1.5 millimeter thickness is already enough to cause problems inside your eye. Now, the weight of the lens is also variable. It increases the older you get, from 135 milligrams when you're young to about 255 milligrams when you're very old. Now, again, why would that be important? Because the lens grows your entire life. It doesn't stop growing. And the older it grows, the thicker it becomes, the heavier it becomes, and the denser it becomes. And because of that density, it will disrupt the transparency of your eye. Now, your lens has two surfaces, the front part and the back part. The front part is a little flatter and the back part is more curved, and at the middle portion these two surfaces meet. We call that the equator. So again, the crystalline lens, it's not shaped the same way in front and at the back. The back is a little more curved. It's actually suspended. It is not floating inside. It's not free floating. It's suspended with zonules. And because of that, that refractive index and the power can be changed. Now, the refractive index is the um, the index of the lens that is important when you're calculating what lenses you should place and how thick the lenses you should place. Now, the total power is about 15 to 16 diopters. Now, it changes the older you go. The At your very, very young age, it could be 14 to 16 diopters, and when you're older, it becomes just a simple 1 to 2 diopters. Now, what does this mean? Now, it means that when you're younger, you can focus on something that's very, very near. You probably noticed that even if your hand is practically in front of your nose, you can still focus on the lines of your hands. But the older you get, you'll have a very difficult time doing that. In fact, by the time you reach 35 to 45 years old, you probably need a reading glasses for you to be able to read something that's very near. Now, the younger you are, the easier for you to change the shape of your lens so that you can focus at something near. You lose that ability the older you get because your lens, as we said before, becomes thicker, denser, and fatter. So the shape could no longer be changed simply by pulling it like what your ciliary muscle does. Now, let's talk about the structure of your lens. It's a very, very small 9 to 10 millimeter structure instrument that it's very, very important. It's something that could basically disrupt your entire life. Now, it's covered by a capsule. It's thin, transparent. It's a hyaline membrane. Now, it's thicker in front than at the back, and it is the thickest at the sides and thinnest at the posterior pole, at the very, very back. Now, why is it important that it's thickest at the equator? Because that is where the cables are attached. That is where it's getting pulled. So that area needs to be very, very strong. Now, this capsule needs to be intact after a cataract surgery. So during cataract surgery, the front part is removed. The lens, the intraocular lens, is placed in the middle of the capsule. So with the modern techniques in cataract surgery, this capsule needs to be intact. Again, we're talking about a very, very thin membrane, about 14 micrometers, and the thinness at that 3 micrometers. It needs to be intact for it to be able to hold the lens, the intraocular lens, so the lens will not float inside your eye. Now, this is how your lens is organized. So it's covered by a capsule, and everything in the lens is actually self-contained. That means the body does not recognize anything inside the lens. When you were an embryo, the eye was already formed. The lens was already formed. So the lens proteins were sequestered before your immune system was already functional. So that means your immune system does not recognize the proteins inside the lens, such that if we should break this capsule and your body should detect anything spilling out from this, it will interpret it as an infection or you're getting invaded, and it will react by it will cause an inflammatory reaction because your body will be fighting it. So that capsule is very important. It keeps the lens intact. It makes sure that when the lens is being pulled, the shape will be intact. And even during after cataract surgery, it needs to be there. It needs to be intact because it will hold the intraocular lens. Now, your lens is particularly unique in such that it has a single layer of cuboidal cells just beneath the anterior capsule. Now, that is the only living area in your entire lens. That single layer of cuboidal cells is the only part of the lens where you can find nucleus inside the cells, because when those cells reach the equatorial regions, those cells start to lose that nucleus and it becomes columnar and becomes fiber. So as long as you're alive, those epithelium will create cells, will rapidly reproduce, and those cells, when they find themselves in the equatorial region, it will keep on multiplying, keep on putting more fibers, one over on top of the other, until you either had the cataract surgery or you die. So it will continue doing this cycle as long as you are alive. Again, just to show you, the center is where the fibers are, and the cortex are laid up on top of this. Now, we talked about an anterior cuboidal epithelium. There is no posterior epithelium. If you find a posterior epithelium, that's pathologic. Usually we see that in radiation exposure victims. Now, the cells that are created, the fibers that are created are piled up on top of each other, and the posterior epithelium that existed when you were an embryo were used, well, to fill up the central cavity of the lens vesicle, well, during the embryonic stages. Again, only the anterior there's only an anterior epithelium. There is no posterior epithelium. If you see that, that's pathologic. It only existed during the embryonic stages. The lens fibers are what happens to the anterior epithelium when they reach the equator. They start to elongate, they become lens fibers, and are laid up on top of each other. Now, it's very, very organized, very similar to the trunks of the tree, those rings that you see in the tree, or onions. The ones at the center are the oldest, the ones at the outermost are the youngest. And they are arranged very, very uniformly, and they're compacted very, 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 very well. Now, why should that be? It's because your lens needs to be transparent, so it needs to be organized. If you disrupt this structure, then by inserting, let's say, big molecules of carbohydrates, sugar, or big blobs of liquid, then you will disrupt this very, very uniform organization, and your lens starts to become opaque. Now, this is a picture of an electron micrograph of the fibers. You notice how they are laid down very, very uniformly, very, very evenly. That is the reason, or one of the reasons, why it is transparent. The nucleus is the center part, and it contains the oldest fiber. Now, there are different zones in the nucleus. You can actually tell when the problem started by trying to identify which zones were involved or became pathologic. Again, the one in the center, that's the nucleus. The embryonic nucleus, that's the very, very center. Okay, that's the innermost part of the nucleus. It corresponds to the first 3 months of gestation. And primarily, these are the lens fibers from the elongation of the cells of the posterior walls of the lens vesicle. The fetal nucleus corresponds to the lens from the 3 months to gestation of gestation until the patient was born. The fibers meet around sutures. Will show you how this looks later on. If it's shaped like a Y, then it's in the front, and if the Y is inverted, it's at the back. This is how it looks. The anterior suture is forms like a upright letter Y, and if it's an inverted letter Y, that's the posterior suture. And the picture on the rightmost is a picture of the suture of the sutures, but this one is easier to see because it became cataractus, it became white. Normally, it should be transparent. In a lot of your patients, you will be able to see the sutures if you focus your microscope well enough. You can see transparent the sutures. So you know that if this is involved or something behind is involved, the problem started when the patient was still in the womb, because the fetal nucleus is up to birth. The infantile nucleus corresponds from birth to puberty. Those are the lenses that you will be able to identify. And the adult nucleus is usually the outermost part of the nucleus. It's from puberty to the rest of your life. If you live to 100 years old, it will still keep building up until the time you have your cataracts taken out. The cortex is the softer part. It's the more peripheral part, which comprises the youngest lens fibers. The nucleus usually is the more compact. You will be able to see later on patients wherein they practically have no cortex, or the cortex have become liquefied already. Now, I told you about the cables that are suspending the lens itself. It's called zonules of Zinn, or suspensory ligaments of the lens. Those are fibers passing from the ciliary body going to the lens. So it holds the lens so that they can control it. So when when the ciliary muscle contracts, it becomes bigger. When the ciliary muscle relaxes, it becomes a little flatter. It also holds the lens in place so it doesn't float inside of your eye. It's always focused in front of your pupil. Now, this is how the zonules look. It's not just one cable. These are a series of cables. It's not just placed in one point. It's spread out in several points. That is the reason why it's controlled the lens is controlled very, very well, and it's very, very strong. It usually can withstand pressures. Like if you got punched in the eye, you don't actually lose your lens automatically. Only with repeated attacks or with a very, very strong blunt attack will you be able to break these zonules. These are very, very strong fibers. It's located around the lens. It's in the equator area, and it's connected to the ciliary body, so where the ciliary muscles are located. Now, a cataract is any opacity in your crystalline lens. So the crystalline lens supposedly is very transparent. If you see an opacity, no matter how small, no matter how big, it's a cataract. It doesn't matter whether the opacity is in the middle, it's at the side, in front, or at the back. If there's an opacity in your lens, it's a cataract. So it's very easy to know what a cataract is. Look at the lens. If it's clear, it's okay. If there's an opacity, no matter how dense, no matter how light, it's a cataract. So cataracts can be congenital and developmental. Now, what do you mean by congenital? If the patient was born with cataracts, then it's a congenital cataract. That means something happened in the womb that disturbed the growth of the lens, and sometimes you'll be able to identify it by simply looking at your patient's eye. Now, a lot of your patients who had congenital cataracts, the parents don't usually know whether the patient was born with cataracts or they just notice the cataracts several months later, because when a child is born, usually you check the fingers, you check the hands. Very, very few parents will actually get a flashlight and shine it on their child's eye just to see if it's clear. Now, if you have one of those patients where the parents have no idea whether their kid was born with cataracts or was something that developed after birth, you ask for pictures. Pictures specifically showing the eyes, because you will be able to notice if there's something blocking the red orange reflex or if you see something white in the patient's eye. Again, parents don't usually look at the patient at their kids' eyes. Very few will. So if their child usually has a congenital cataract, most of the time they won't notice it until several months later. But that doesn't mean that it wasn't there when the child was born. Again, look, if it's a smaller pathology, then it could be limited to just the center, the fetal nucleus, or it could be very, very small like this. Sometimes you will notice this only when the child is already old and has come to you for a regular consultation, because a cataract this small will be missed. Now, a developmental cataract is something that happened from infancy to adolescence. So if your patient's cataract happened after birth, it should happen outside of the Y sutures, or at least start when after the patient was born. So very, very particular, it affects the area where when when the disturbance happened. I'll show you a picture of that later. So something unique about developmental cataracts is if the pathology was short-lived, the areas behind it and in front of it will be clear. So here's an example of that phenomenon. You have a patient with a cataract in the middle. You can see an infantile cataract, and then you see a clear area after that, and then another area of opacity. It looks like it's a planet Saturn with rings, and then after that ring opacity, you now have clear lenses. So the pathology, the disturbance, the lesion that created this cataract was short-lived, and when the pathology resolved, the fibers laid after that would be clear. If it should recur, it will be opaque again, and after it disappears again, it would be clear fibers again. This from the skin of the patient, you know this is a very young patient. This is actually a 12-year-old boy who I operated on about 10 years ago. You can see the the very, very thick central cataract and the thinner opacity at the edges. They became opaque only after the patient got past about 10 years old, but the center one was there even at birth. Now, I need to warn you about congenital cataracts, not just because you saw a leukocoria, which means you saw something white in the pupils. It's already a cataract. The most common diagnosis would be cataracts. But there are important differential diagnoses that you should be able to rule out because they're very, very dangerous. These differential diagnoses are rare, but it could kill the patient. In particular, retinoblastoma. Retinoblastoma is basically a cancer inside the eye. It grows fast, and if it should escape the eye, the patient would most likely die within the next 5 years. Again, there's retinopathy of prematurity. Usually will happen in underweight kids who are born premature. In it used to be it used to be thought that when kids are premature and born very prematurely, they will be given very, very high oxygen doses. It used to be thought that it's the oxygen dose that causes it. Right now, it's we're thinking more along the line of the weight of the patient. It giving a premature baby very, very high oxygen very to inhale is actually justified because their lungs are not that developed yet. However, it does affect the maturity of the retina, and retinopathy of prematurity could cause a leukocoria it if it reaches the stages of retinal detachment. Again, a little more benign than the first two would be persistent hyperplastic primary vitreous. If you remember your embryology lectures, your lens, when it was created, had a blood vessel connected at the back. But when you're born, this blood vessel atrophies and disappears, much like your umbilical cord. And it should disappear completely. But in a few cases of your patients, some remnant will be left, and these remnants are usually opaque. I'll show you examples of all these three. Now, this is a boy with retinoblastoma. If you look closely, at first glance you'd think, oh, it's cataracts. The boy has cataracts because of that white pupil. Unfortunately, this is actually retinoblastoma, and treatment for this particular patient would be enucleation. Again, this is another this is another example of the patient with retinoblastoma. This is a simple test, a simple ROR test, or red orange reflex. You shine a light through the patient's eye and see the light being reflected back. It should be like the one on the left, that bright orange light. The one on the right is not reflecting light back because there's a growing retinoblastoma on the left eye. This is a retinopathy of prematurity, again presenting with leukocoria, white pupil, because the retina became detached and it's no longer red orange. It's now actually white because of the detachment. So it's important that these first two cases you should be able to refer immediately because time is of the essence in trying to save these patients. Retinopathy of prematurity patients will usually become blind if their retina detaches completely, and retinoblastoma patients can die if you dilly-dally in referring them or treating them because you thought it was a simple cataract. Now, this one is a PHPV, or persistent hyperplastic primary vessel. Now, that small knob on your left is where where it's attached in the optic disc, and the blood vessel did not atrophy and remained attached to the back of the lens, so creating an opacity. It's very easy to actually remove this later on. But cataracts are mostly acquired and 90 to 95% of the patients that you will see with cataracts are actually acquired cataracts. In areas where there is very very good medical facilities and medical benefits, you will rarely see a congenital or a developmental cataracts past the age of 10. Most of the cases you will see will be acquired cataract. The most common will be the ones highlighted here: senile cataracts, traumatic cataracts, and metabolic cataracts. And by their name, senile cataracts are found in the elderly, traumatic cataracts are because of trauma, and metabolic cataracts are because of problems in your metabolism like diabetes and galactosemia. Of these two, diabetes would be more common. Getting electrocuted, especially if the electric current would pass through the eye, could cause an electric cataract. Radiation cataracts are also seen in patients with very high exposures in radiation, and toxic cataracts are those the one responding to treatment or chemicals like steroids, medications like myotics, or in Wilson's disease, you see the case of Fletcher ring and the sunflower cataracts. You can also see cataracts associated with other systems of the body. Patients with skin diseases could also have cataracts because of the skin diseases. We call this syndermatotic cataracts. Now, these skin diseases usually affect the area around the eye. Cataracts could also be seen with bone problems or osseous diseases, or as a part of miscellaneous syndromes like dystrophica myotonica, Down syndrome, Lowe syndrome, and Treacher-Collins syndrome. I'll show you later on a picture of a particular cataract associated with dystrophica myotonica, and you will never forget one. Now, let's say your patient has cataracts. What do you expect your patients to feel? Or what will they tell you during your interview that will actually give you a clue that they have cataracts even without examining or looking at the patients? First, your patients will be saying that their vision is blurred, usually described as cloudy or smoky. It's like wearing a pair of glasses that somebody kept touching the lens. So it's very, very blurred. Although usually you can make out the shapes, you can make out the colors. The thicker the cataract, the more blurred it becomes. Also, it's also very important where the cataract is. If the cataract is at the sides, there will not be much blurring until the later stages. If the cataract is in the middle, then your vision will blur even if the cataract is very, very small. Your patients will also be reporting difficulty at night. So don't mistake this with night blindness. They will just say that when it's nighttime, they find it more difficult. The best way to differentiate night blindness because of a retinal problem or because of a cataract is to examine the patient. Patients with cataracts also report double vision. In particular, they're unique that their double vision could be even in just one eye. Usually when our patient says, I have doubling of my vision, I see two of everything. If you cover one eye, the double vision disappears because of alignment problems. But cataracts could cause double vision even if one eye is covered. It's because the cataract itself diffracts the light. It bends the light such that you see a clear object and a hazy after effect. It's actually the light that was bent by your cataracts. Your patients will also be telling you that they're very sensitive to light. They have glare, especially when they get hit by oncoming headlights of the cars when they're driving at night. They will tell you that they get easily blinded by oncoming cars. their eyes become very sensitive to light. It's again because the cataract is bending the light and spreading it all throughout the eye. Your patients will also be telling you the colors look faded. In particular, red becomes pinkish, or in this case, a little rose colored. The blue could be mistaken for green. The green could be mistaken for blue. White would look like washed out uh, white. It will become a little beige. It's because the cataracts again disturb your perception of colors. Your patients will also notice that they will need a very very bright light when reading, and before they can read anywhere, but now they will need to look for a very very bright source of light before they could read or do some near work. So how do you diagnose a patient with cataracts? The simplest one is to examine the patient. Even a simple flashlight, a simple magnifying glass could allow you to examine a patient. So you don't have to be in a fancy eye center or in a fancy hospital to be able to diagnose cataracts. You can do it with a flashlight and a magnifying glass. Now this patient is dilated just to be able to show you clearly how a cataract looks. The cataract should be searched for behind the pupil. It's not going to be in front. It's not going to be outside of the eye. It needs to be behind the pupil. So if your pupil is very very small, you will need to dilate your patient. So a simple flashlight, a simple magnifying glass, it will work. If you have an ophthalmoscope, just uh, switch it to the green 20. You can use it as an illuminated magnifying glass. Or if you have access to more advanced equipment, then it would be better and easier for you. What you're looking for when you're using an ophthalmoscope or any flashlight is the red orange reflex. When you shine the light in front of your patient's eye, they should look like this: bright orange, round orange without any disturbance. In this patient, if you notice the one on the left, the one on your right, that's the eye with the disturbance. It's a cataract. So it's using the phenomenon of a retroillumination. You can see that there's a disturbance. The big bright red light should be very very clear and undisturbed, and the one on your right would be obviously disturbed because of the cataracts. If you have access to advanced equipments like a slit lamp, it will give you a magnified view of the patient and can give you even layers of the cataract. But diagnosing a simple cataract, you only need flashlight and a magnifying glass. A slit lamp will give you a more detailed examination. Like this one, it's actually a posterior subcapsular cataract. The cataract is at the very back of the lens. This one is a little more difficult to diagnose with a simple flashlight, but could easily be diagnosed by an ophthalmoscope or by retroillumination looking at the red-orange reflex. The slit lamp would be able to give you this magnified view, enabling you to determine exactly where the layer of the cataracts is. Okay, I showed you differential diagnosis previously, the important ones, the retinoblastoma, the premature retinopathy of prematurity, and the PHPV. The other differential diagnosis, which is usually confusing for the patient because when they ask what cataract is, people usually just describe it as white in the eye. So a lot of patients will go to the hospital telling the doctor that they have a cataract, and when you look at the patient, they actually have this. It's a pterygium. A pterygium is outside, it's in front of the eye. A cataract is inside the eye. The pterygium could easily be treated with a simple excision. A cataract would need to have a more major surgery because it's inside the eye. Again, don't forget, this is not a cataract. This is an emergency. This is retinoblastoma. Refer the patient immediately to the nearest center or specialized area in your hospital, because this is not just a cataract that you can ignore and say, we'll wait, look at it next year and see if it worsens. This could kill your patient. Now, a cataract doesn't just happen. It matures like fruit. That's the reason why a mature cataract is called ripe. It's because a lot of doctors describe cataracts like fruits. They mature. The favorite would be mangoes, because they change color very, very obviously from green to yellow, and when it's past maturity, it becomes black. So what are the stages of maturity for cataracts? So we have these are the major stages. It's immature, mature, hypermature, and Morgagnian. We'll go over them later. The earliest sign of a cataract is called lamellar separation. That means the layers of your lens start to separate, usually by fluid. Now, if you can remove that fluid, these changes could still be reversible. Usually, it will just look like this, just layers of clear and a little opaque, very, very small layers, just fluids. So somehow, if you can remove those fluids, usually by either medication or other forms of treatment, then the clarity of the lens should return. But if it doesn't return, the next stage would be incipient cataract. That means it's very, very early. Now, you just see areas of opacity with clear areas that are visible in between them. So these are cortical cataracts. You can see the clear areas and the opaque areas. Usually, this starts at the sides of the eye or at the very edges. Next would be the immature. Usually, most of the cataracts that you will encounter will be in the immature stage. This is where the opacification goes further. The lens would appear a little grayish white, or the bluish tint of your lens will disappear, but you will still be able to see clear cortex. So some areas would still be clear. In some patients, the lens actually gets fatter because fluid gets inside and it hydrates. It becomes an intumescent cataract, meaning it's fat enough that it's actually creating a problem in your anterior chamber, and it becomes shallow. The anterior chamber becomes shallow, creating a very, very heavy risk for your patient in developing glaucoma. Again, immature would still have some clear areas of cortex. Mature usually does not. Hypermature is when it becomes white. We'll show you pictures of that later. And Morgagnians. Now, a mature cataract is a complete opacification. So everything is now opaque and the lens becomes pearly white, and such a cataract could also be labeled as ripe cataract, again because of the propensity of a lot of doctors to describe cataracts like they describe fruits. Now, used with the previous techniques in cataract surgery, it's very important for your doctor to wait until your cataract is mature or ripe before they do surgery, because ECCE, which was the dominant technique done at the time, or the ICCE, requires your cataract to be very, very hard for them to be able to easily remove it. With technology that you don't have to wait until your cataracts are mature, it can be removed at any stage, because phacoemulsification, the predominant technique that being practiced now, allows you to be able to remove even the cataract even if it's soft. You don't have to wait until your cataract is mature to have it treated. Again, this is how how a mature cataract looks. You can very easily see the very opaque central nucleus. A hypermature cataract is when, well, you got past mature. Most of the time, when doctors see a white cataract, one that's really very white, they call it hypermature. Well, in the books, it's just described as mature. But if you ignore the cataract, even though you cannot see with it anymore, which is what a lot of our patients, especially those without access to medical treatment, that's their problem. They don't have access to medical treatment, so their cataract is just left until it gets worse. So the cataracts are actually painless, unless you develop some sort of complications. And since they're painless, a lot of patients really don't have it treated. Most of our patients will wait until there's pain before they run to the hospital. Now, this is a Morgagnian cataract. It's a picture wherein the entire cortex now liquefies. It's no longer fibers, it's now liquid. And the lens, which is very dense, is actually floating inside of this bag of liquid. Now, the lens, which is actually floating, actually bounces around like the small eye, the eye of a doll. When you shake the doll, the eye actually shakes also. It also happens to this patient. When you ask the patient to look left or look right, the lens will bounce left and right. If you ask the patient to look up and down, that nucleus will bounce up and down. Now, let's say you still ignored it even at this stage. You left it untreated. The patient says, I don't have access anyway, so I cannot have it treated. It becomes a sclerotic type of cataract, meaning the fluid in the cortex leaked out and left the nucleus there. The front capsule and the back capsule was already touching and fused together. So the white plaque that you see in the middle is actually the anterior capsule fusing with the posterior capsule. The brown at the edge of that white is the nucleus being pushed to the sides. It's now donut shape instead of instead of looking like a bean. Now, remember what we said earlier, being that the protein inside the eye is unknown to your body. It doesn't recognize the proteins inside the eye. So what happens when it leaks? When the capsule leaks and those fluid escapes, your eye develops a very severe inflammatory reaction. It's called uveitis, and the eye becomes swollen, the eye becomes very red, and vision really is compromised. Now, not all cataracts behave the same way. Usually, you will see special cases of cataracts, such as traumatic cataracts. When you see the rosette type, the flower type, this is a traumatic cataract from a patient that was punched. You probably noticed the opacity stopped at a certain point, and then it became, the rest of the lens is already clear again, because that part happened after those parts of the lens were laid down after the trauma happened. So the patient was punched. In about 10 years, you saw the patient, you see this cataract, but you also see about 10 years worth of clear fibers being laid around that rosette. So this is a traumatic cataract. You will also see blue dot cataracts or cerulean cataracts. This is another example of a cerulean or blue dot cataract. These are genetic. These are autosomal or genetically passed on. You will find this in your patients, and if they are still in this stage, patient will say, I didn't even notice that I have a problem. But when they grow older, this problem becomes denser, it becomes more compact, and your patient will now start to complain of blurring of vision. Removing this cataract will actually restore your patient's vision to near normal. Your patient could also develop cataracts because of other diseases, in this case of uveitis. The difference with uveitis is the iris becomes very sticky, it sticks to your lens. So aside from having opacity in the lens, you could also have everything slapped together, sticking together inside the eye, making it more difficult for you to do the surgery. Also, uveitic cataract has the habit of recurring having a you have a risk of having an inflammatory reaction being triggered after the cataract surgery. Now this one is called a Christmas tree cataract, or sometimes a snowflake cataract. You see this in myotonic dystrophy we showed you earlier. It's one of the more miscellaneous syndromes. Now, usually the patients are tolerant of this, but if it becomes thicker and more central, your patient will now start to have problems in their vision. Removing this cataract will make it will restore your patient's vision. Now this one is an electric cataract. So the electric current passed through the patient's eye, creating this star-like cataract. Again, removing the cataract, replacing it with the intraocular lens should restore the patient's vision. Now, sometimes you will hear the term brunescent cataract. It just describes the color. Brunescent cataract is something that you use to describe when you see brown inside the eye. It means a very, very thick, very, very dense cataract. It gives your surgeon warning that they're going to deal with the very dense and hard cataracts. So, whenever you hear the word brunescent, it's basically just describing how the cataract looks. And they're basically describing this color. It's like burned sugar color. Now, you will also hear the term black cataract, which is basically just another term for the brunescent cataract. So, a black cataract and a brunescent cataract, they mean the same thing. It's a very, very dense cataract. And as I showed you before, this one is a posterior subcapsular cataract. The cataract is just at the back of the eye. Now, this one is very, very disturbing because even if it's very small, the patient's vision deteriorates very, very rapidly. Again, removing the cataracts would improve your patient's vision. However, posterior subcapsular cataracts are more often seen in patients with diabetes or patients that are using steroids. Okay, so this one is a posterior capsule opacity, otherwise called a secondary cataract. Now, this patient already had the cataract removed and the intraocular lens was placed. You notice that I said earlier the capsule needs to be intact. That's what you see here. You see the capsule that's still intact. However, it thickens after some time. That means some of the cells in the anterior capsule and the anterior subcapsular area survived and multiplied, or the membrane just thickened. It's called a secondary cataract because it's a cataract that happens after the real cataract. But this is just the membrane becoming thicker, and you no longer need to undergo any surgeries for this because it's treated with lasers, just a YAG capsulotomy which should take something like 2 minutes to perform without reopening the eye. Now, how do you grade the cataract? We showed you a lot of different cataracts. So how do you grade them? How do you write them in the records or in the charts such that the next person who sees them knows that the cataract actually got worse or got better compared when they were previously seen? So there are a lot of grading system. Almost every major university has their own grading system, but the most commonly used grading system is called the LOC 3, or Lens Opacities Classification System 3. They call it 3 because they had 1, they had 2, and this is the third version. Now, the way to use this is you need to get a copy of this picture and paste it near your slit lamp or your examination table. Whenever you look at the patient, you look at the picture, compare what you see in the patient, and the grades would be the letters that are inscribed below. The line on top is called nuclear cataracts. The one in the middle is cortical cataracts, and the one at the back are the posterior subcapsular cataracts. The first line is using a slit lamp. The second line is just using the red-orange reflex or just an ophthalmoscope. The last line would again just a retroillumination from or using the red-orange reflex. You look at your patient and then look at the picture. If that is what you see, that is their grade. Now, the WHO created a simpler version because the first part needs you to have a slit lamp or something to actually see the retroillumination of the patient. So this one came from the WHO. This is their simplified grading system. They actually have 2 more. But just looking at the eye, again, comparing it with the picture that you see, so you either write down NUC1, NUC2, or NUC3, or meaning nuclear cataract 1, nuclear cataract 2, or nuclear cataract 3, depending on how thick the lenses are. If there are no cataracts in the nucleus, then you write NUC0. Okay, so you know your patient has cataracts. You talk to your patients. What they described are symptoms of cataract. What you saw when you examined the patient were cataracts. So how do you treat the cataracts? So again, before we start, I would like to inform you that you need to be critical when you're looking at your patient's cataracts. When you're measuring the patient's vision and your patient's vision is really very, very bad, and when you check their cataracts, it's an early cataract, it's a very light cataract, such that it's impossible for the cataract to be causing that severe problem in the vision. That means there's something else happening to the patient aside from the cataract. Okay, so before you focus on treating the cataracts, try to think, is what I saw able to explain what the patient can see? So there are 3 types of treatment: medical, refractive, and surgical. I crossed out medical because I need you to understand that there is no medical treatment for cataracts. If you look at the newspaper, if you look at social media, if you look at magazines, you will see advertisements for treatment for cataracts needing only drops, sometimes tablets, sometimes combination of drops and tablets. I can tell you right now that there are no proven medical treatment for cataracts. Cataracts cannot be reversed medically. But since you see a lot of this being advertised, patients are prone to think that these are true, these are accurate, because you see them all over in the advertisement. And you will notice that all the while their proof of effectivity are just testimonies from previous patients, or you don't even know if they're previous patients, but basically just testimonies. Okay, again, there are no medical treatment for cataracts. Cataracts cannot be reversed using medications, using drops. There are no treatments yet. Okay, so don't believe people saying doctors were just trying to hide it because they don't want people to know. Of course, you want people to, if it works, they want people to know. If it really works, you don't need to do surgery, which is stressful for the doctors. It's easier for us to just give the patient medication. So there are no proven medical treatment for cataracts. Okay, so what you're left with is refractive and surgical. Refractive means giving your patients glasses. But what do you mean by just giving patients glasses? How do you know that the patient would need glasses? Because the other treatment would be surgery. Okay? If the patient have cataracts this early, if you notice it's a very, very light cataract, patient's vision is 20/20. Sometimes 20/25, sometimes 20/30. But their vision would not be that bad to necessitate an immediate surgery. So you can give them glasses. Just give them glasses, and usually it improved their vision. But you have to tell the patients it will not reverse the cloudiness. It will not reverse the smoky vision. Those will only be gone once the cataract has been removed. So even if your patient has a very, very early cataract, they may request that you have the surgery done, especially if their livelihood requires very, very accurate vision. For example, they're architects, they're engineers, they're painters. You can do surgery earlier. Okay, one of the most famous Philippine artists, Philippine painter named Amor Solo, I think you recognize that name, have had cataracts. So you know this because in his early works, his paintings are very, very bright, colorful paintings of the idyllic countryside. And then you notice somewhere between somewhere at the later stages of his life, when he was very, very old, his paintings started to change. They become very, very, very bright, from bright to subtle to something that's very, very strong colors. It was found out that he had cataracts, and he didn't have the cataracts removed until it was mature, which was traditional at the time. So during the time that his cataract was maturing, his cataract was already interfering with his mixture of colors. So he thought he was still mixing the proper colors, but now the color palette has changed. It's now very, very bright because his cataract was interpreting it as some just simply colorful or a little faded. So the treatment in the books, in the journals, the only treatment that will reverse cataracts will be surgical treatment. And we've come a long way from the early days of doctors treating cataracts. The first one would be couching, which is never done anymore. The other one would be ICCE, which is the common surgery done in the before the 1990s, from as far as 1990. ECCE is the treatment that was done roughly in the 1990s to early 2000. Right now, it's phacoemulsification. And later on, gaining in popularity is the laser-assisted. The only thing that's holding the laser-assisted back is it's very expensive. It uses a femtosecond laser, very similar to the one being used in LASIK. It uses it to assist your phacoemulsification surgery. So it's still phacoemulsification, but you're using lasers to assist your surgery. So couching is basically getting a stick In fancy hospitals, they use a fancy stick. If you're going to a provincial or a barrio doctor, then he'll probably be using just a piece of wooden stick. They'll hit the eye repeatedly until the cataract floats into the vitreous. Okay, so it's a little barbaric by our standards, but at the time, there's their only treatment. Of course, you know that there will be bleeding. Of course, you know that not everybody will respond to this treatment. However, that's the only option that they have when they have cataracts. When you have cataracts and you're old, in the 1800s or even earlier, and you don't have access to proper medical treatment, that is the only treatment available. Unfortunately, some big hospitals, even in Europe, used couching before they were able to develop the more fancy cataract surgeries. ICCE and ECCE came about later on. So ECCE, or extracapsular cataract extraction, means that you remove the cataract but leave behind the capsule. You use the capsule to hold the intraocular lens. ICCE just means the cataract was removed including the capsule, because it was the technique developed before we were able to invent the intraocular lens. The intraocular lens did not become mainstream until the 1900s. So basically, it's just about 30, about 30 years old. So if you know anybody who had undergone surgery, cataract surgery, more than 30 years ago, the possibility is they don't have an intraocular lens. What they have is a very, very thick pair of eyeglasses. And as you can see in the picture, they're actually squeezing the eye so that the lens would slide out. Right now, we do phacoemulsification. Phacoemulsification needs a smaller incision, so you can insert an instrument, and once the cataract has been completely removed, that instrument, by the way, is the tip vibrates. It uses an ultrasound and to break up the cataract, and it's a tube, so the broken pieces could be suctioned off through the handpiece. After the cataract is cleaned, the lens is inserted. Again, it's a foldable lens. Once inside, it unfolds. It's very similar to the Spanish fans, or in the Philippines we call it folding fans, or I think you see those in Japanese and Chinese folk dances. They come in folded up, and then when they get inside, they unfold. So that's the intraocular lens, and the intraocular lens usually is computed with power, so that you probably won't need glasses anymore after the surgery. Again, probably. So this is the picture of the femtosecond assisted. This is the called Lens SX from the company Alcon. This is the first femtosecond assisted laser cataract surgery that was done in the Philippines. The surgeon is Dr. Cesar Espiritu. He's one of my mentors who taught me how to perform surgery. Again, the problem with this machine is it's very expensive. You have to put the price of the machine on top of all your other expenses, and that makes it prohibitive and not yet mainstream at this time. But all surgeries right now, all modern surgeries, are micro surgeries. It's usually done with a team. It's not a one-man job. You have people assisting the doctor. You have nurses assisting the doctors. You have machines trying to regulate the input and output of the fluids inside the eye. It's usually described as pain-free. It's usually described as no blood, because there practically is no blood. It's a clear cornea approach. and there are no blood vessels in the in the cornea. There are it's also promised as a non-suture approach, as you saw earlier. It's very very small. It's this we approach it in a way it's self-sealing, and patient recovery is very very fast. Usually we count it in days, not in weeks, not in months. And the anesthesia right now mostly is topical. We still use general anesthesia in special cases. We still use topical local anesthesia in special cases, but more often than not, it's going to be a topical procedure. And the main beneficiary of these improvements in technology, in skill, are our patients. So this one is a surgery done in India. The difference with some surgery is we don't patch them anymore. We just give them goggles so they can see. But when your patient is in a more rural area, you might want to cover it just to make sure that the patient doesn't get the eye infected. It's still a surgery, so your risk of infection is still there, although it's now very very minimal. We rarely see infections anymore. Uh, as far back as decades ago, we see surgeries with infections, but right now it's no longer the case. We've developed high enough that cataract surgeries are safe and very very fast. So thank you, and if you have any questions, please don't hesitate to put them in the comments. Thank you very much.